Welcome everyone on this webinar on the safety of contraceptives for young people. I'm Emilie Peeters, I'm the Advocacy Officer at RHSC, and I'm very happy to see so many of you at this webinar that's organized by our youth group within the Reproductive Health Supplies Coalition. We saw that within our group we had quite a lot of questions from young people on how do we really know that reproductive health products available for young people are safe, and how do we know they're really included in the trials that are happening around contraceptives. And so that's why we decided to organize this webinar, and we have a very interesting panel for you today. We start with Clarissa Lord Brundage from the Bill and Melinda Gates Foundation. She will give an introduction on adolescents and young people and how they're a key population to achieve not only the FP 2020 goals but also the Sustainable Development Goals and the need to design products that meet their needs. After that, we'll go to Professor Melissa Gilliam from the University of Chicago. She will give us some more explanation about how minors are included in contraceptive clinical and behavioral trials. And then we'll go to John Townsend from the Population Council, but also the president of the Reproductive Health Supplies Coalition, and he'll explain a bit more about informed consent and ethics that are used when it comes to young people. At the end of our webinar, we'll have a question and answer session. And so I would encourage everyone to ask questions. You can do it in two ways. One is you'll see a question box on your right side of your screen. You can just type in your question and I'll try to collate all the questions and ask them to our panelists. Or you also see a little hand on the left corner of the box on your screen, and you can raise that hand so I can see it, and then I can give you the floor to ask a question. So I think we can give it a start. We'll start as mentioned but with Clarissa Lord Brundage. So Clarissa, the floor is yours.
Great, thanks so much, Emilie, and good morning, everyone, or good afternoon, good evening, wherever you are. I was just thinking this back in October when you had the RHSC meeting here in Seattle, and this webinar, I think, was a twinkle in your eyes, Emilie, so it's great to have the opportunity to have this conversation this morning. I am a program officer on the family planning team at the Bill and Melinda Gates Foundation, and I focus on adolescents and youth, and just have a few minutes of remarks as it relates to adolescents and youth in our strategy and contraceptive technology in our strategy. I think, as all of us on the phone today know, the largest generation of young people in history have entered their reproductive years and have a need for quality contraceptive technology that meets their needs. Adolescence is a time when habits are formed, and reaching adolescence early and often can instill not only positive and healthy behaviors that have a lifelong impact, but also can support their lifelong contraceptive use as they are trying to achieve their intentions of whether and when to have children. We also know that ensuring that young people have appropriate information, skills, and contraceptive services that are appropriate for their life stage and that are not discriminated against is critical to achieving both our FP 2020 and universal access goals. Yet we also know significant challenges stand in the way of making these contraceptives more widely available and accessible. And the challenges range from including insufficient donor and developing country funding, from weak distribution systems, lack of monitoring and data collection mechanisms, cultural and knowledge barriers, and also a lack of appropriate products that meet users' needs, including the needs of young people. Our immediate efforts to reach an additional 120 million women and girls and adolescents by the year 2020 will help this Yet we know 70% of unmet need is due to method-related reasons. So there's a real gap that we have to ensure that we are designing products and methods that meet women's needs and that address side effect barriers. A big driver to reduce these method-related reasons for non-use is improving tolerability with current methods. So one of the things that we're focused on within the context of the Bill and Melinda Gates Foundation and our strategy is designing new products that address user barriers. And some of the barriers that we've identified specifically for young women, excuse me, that's my dog, specifically for young women are the need for discretion and easy access. So methods that can be accessed perhaps outside of the health system that don't require them going into the clinic or perhaps seeing a medical professional where they can face stigma and discrimination. So I'll just perhaps end by saying that all young people should expect to receive high quality information and services no matter where they go to meet their family planning needs. And they should also expect to have an access to a range of contraceptive options that also meet their needs and that are safe for them to use. So I will look forward to hearing Melissa's presentation, and we'll hand it over to her, and happy to answer any questions at the end of this session.
Hi, can you hear me?
I can hear you, Melissa.
Okay, perfect. Okay. So hi, everyone. Thank you so much for taking the time to participate in this webinar. What I wanted to do is to talk a bit about contraception, what we know about safety, and to talk about how we approach clinical trials research. Are you able to see my screen?
I can see the screen, Melissa.
Excellent, thank you. So when we're thinking about family planning, we want to think about it in the context of sexual and reproductive health across the life course. And so I would point out that contraception and family planning are just one element of safe and important and comprehensive reproductive health across the life course. And so this means access to having a healthy pregnancy and safe childbirth, preventing pregnancy, preventing sexually transmitted infection, access to prevent and making sure that we prevent violence against women, making sure that there are services, social and legal services, and also comprehensive and accurate information about sexuality. One of the ways that we think about contraception is about its effectiveness, and this has been a very helpful table from the World Health Organization that gives you a sense of the array of contraceptive methods available. And I'll actually use this time to go through each of these a little more carefully, and also to talk about some of the issues associated with safety. But what you all wanted to know is, how do we know what makes a method safe, and how much research has gone on with these methods before they're actually brought to the public, and also what happens with research around contraception in young people. So just to situate us, I want to give you a sense of how clinical trials work. One thing that's important to understand is before any method ever comes to market, it's gone through study after study, and then it goes through a number of approvals before it's ever actually seen and used widely among the public. So the first thing that happens is a phase 1 research trial. And this is after any type of animal studies or other things that are just trying to understand the methods. And another thing to realize about contraception is it's been studied for many, many years. And predominantly what we're talking about are hormonally based contraceptives. And hormonally based contraceptives have been studied, again, for decades, for over 50, 60 years of study, and actually been marketed for for quite a while. So we do know a lot about contraception. We know a lot about its effects on the body. But let me at least just tell you, in any drug, no matter what type, contraception or not, what that process looks like. So the first thing is a phase 1 study. This is a new test or a new drug or treatment in a very small group of people. And it's trying to understand whether it's safe, what's the best dose to use, and what are the potential side effects. Once those early safety parameters are established, then it's given to a larger group of people to say, is it still effective if we use it in this wider variety, different types of people? And then the phase 3 studies are in a much larger group of people. Now we're talking hundreds of people. We're looking at side effects, and people who participate in these studies mark down every single thing that they experience, and then the investigators try to say, is this from the drug, or is it directly from the drug? Is it a possible side effect? And that's what you're seeing in the patient packet label. All of those things are the things that people experience in the clinical trial. Often in a phase 3 trial, you're also comparing it to another treatment. And so people are typically randomized to a standard treatment, so a birth control pill versus another birth control pill, a new IUD versus another. And again, it gives you a sense of the safety relative to existing methods on the market. The other thing that's very important is that after a drug is approved, there's often what we call post-marketing studies. These are phase 4 studies, which means that phase 3 is not the final word. And this is important because often this is where you get the variation in patient population. This is where you're using it in lots and lots of different types of people. Phase 3, they often try to have the most kind of clean and data, and so they want the patients who are always going to come back and who aren't going to be lost to follow-up. But phase 3 is what happens in the real world, what happens when it's in everyday use, but that's often still a time to get information. I'm going to talk a little bit about the different contraceptive options, and these are things that have now gone through all 3 phases of those studies, and many of them are still undergoing phase 4 information. And one of the reasons I point these out is because it's important for us to understand, one, how often these are being used and how prevalent the use is, but also we often think about safety and risk, but what we often are not aware of are the health benefits. So with each method, I'm also going to point out the health benefits. So as you know, there's both the male condom as well as the female condom. And these slides just give you a little bit of a sense of the cost, some of the failure rates, and how they work. There's also been a lot of information and attention to long-acting methods of contraception, and these are some of the ones that are currently available in the United States, and not including some of the newer ones that have become available in the United States and in other places, but it at least gives you a sense of the array of long-acting methods. And so the implants, in other places there's Jadel, which is 2 rods, and other places still have Norplant, which is 6 rods. But the implant is an implantable contraception that can last typically for 3 years, and this is a progestin-only method, and it inhibits ovulation. There are actually very few contraindications for implants, except for having current breast cancer, and then there's some what we call relative contraindications. And so this would be history of breast cancer, someone who has a current stroke. But what you'll see is overall the progestin methods are very, very safe. And one way of thinking about it is that progesterone is something that we have in our bodies, and it's very well tolerated. And this is one of the contraceptives that if you have risks of blood clots or other things like that, progestin methods are the ones that tend to be safe. So there are some, as you'll see, there's some contraindications for some of the active heart disease. IUDs are implants that go into, devices that go into the uterus, and they're very, very effective at preventing pregnancy. So when I showed you that chart at the beginning, IUDs and implants are way at the top for being some of the most effective. And one of the main reasons is that you don't have to remember to take them, and so that's one way that they are really good at preventing pregnancy. And these are some of the reasons that you would not take it. If you had a current infection, or in Category 4 means you should never use them in these situations. If you're having some type of vaginal bleeding that is unexplained, but you can see for the most part it's safe. IUDs are safe in most people, and we can talk about it later, but there's research saying that these could be frontline methods in adolescents. Depo-Provera is given as a shot every 3 months. It's given either into the muscle or into the subcutaneous tissue, and again, it's very, very effective, and its role is to suppress ovulation. It prevents ovulation. It prevents sperm from entering into the uterus, and so it's very effective. They're very, again, this is as a progestin-only method, it's actually safe for very many people. So current breast cancer, and that's because some breast cancers, not all breast cancers, are sensitive to progestin. But overall, you'll see very few reasons that someone could not use Depo-Provera. Then combination hormonal contraceptives, these can be in the form of a pill, a patch, or a ring, and all of these that are currently available include a progestin and an estrogen. And so one of the issues with estrogen is that for some people who are higher risk of blood clots, that the estrogen can be a problem for them, and so those are patients that we wouldn't use a combined hormonal contraception. But one thing I also want to point out is that there's actually a lot of safety and actually health prevention that's associated with combined hormonal contraception, and I should have pointed those out for some of the other methods as well. So one thing to know is that anybody who's ever been on a combined oral contraceptive or a combined hormonal contraception actually has a decreased risk of cancer of the ovary, has a decreased risk of cancer of the uterus, and maybe a decreased risk of cancer of the colon. The reduction actually lasts for a long time, and so it starts early, and it actually continues over time. But anyone who's using these methods, and I use these a lot in very young adolescents because they often come with menstrual problems that are actually treated with contraception. And so for patients who have very heavy menstrual periods, have very painful menstrual periods, these are actually a treatment that we use. And then there are other factors, things like having less acne, less hair growth, and as I said, painful periods or even pelvic pain. The important thing when you're thinking about safety is making sure that you've very carefully screened out people who should not be using these methods. And so these are people who have had some type of blood clot in their legs, so a deep vein thrombosis, severe, some type of vascular disease, or have a history of a clotting disorder. If someone had breast cancer or had vaginal bleeding that could be due to a cancer, you wouldn't want to put them on these methods. And also people with high blood pressure or who have migraines with aura, which means seeing lots of visual light symptoms. And so there are people who we know we should not be using these methods in. And a lot of these data are coming from the very, very long history of using these methods, but also what we find in phase 3 trials. When we think about safety, what often that will come from the phase 4 trials. And so I wanted to talk to you a little bit about whether young people are actually participating in clinical trials. And the answer is yes. So in the United States, the National Institutes of Health and the Food and Drug Administration said, you know, this is a problem if we are going to prescribe medications to young people but they're not actually participating in the clinical trials. And so there has now been a very strong movement to include young people in clinical trials of contraception. So right now I'm involved in 2 contraceptive trials, and we have people in them as young as 16. And so this is actually a really important part of research, and you can understand why some people would say, oh, I don't want to have a child in a study, but this has been a push to include young people in those early stages. The second place is actually in phase 4. So after a product is on the market and being used, other people are conducting research on these products. So I just wanted to show you an example of how we've learned a lot about contraception in young people, and that's the Contraceptive Choice Project. And this is really more of a study to try to understand what happens if people have contraception available to them free of charge. But we also learned a lot about the biology of these methods and about preferences and side effects and what people liked and didn't like. And so they have a wonderful website, and these are data from that website, but that would be a place to look if you wanted to get more information. Specifically, they had very high rates of using both the implant and the intrauterine device, and among adolescents of all ages. And so I would refer you to that site as a great resource. And what you can see is when people were able to choose, among the 14 to 17-year-olds, 2/3 chose a long-acting method. And among the 18 to 20-year-olds, again, very high rates of choosing a long-acting method. And they were able to show that that using these methods and being part of the choice study, regardless of what you chose, for young people actually had a really important effect on both the pregnancy rate, the birth rate, as well as the abortion rate. And so the lighter color just shows generally for the United States. The darker color shows what happened among people in the choice study. And these data are for younger people, showing that for each age group there's a significant decrease in all of these things. So, as you go forward, you're going to want to say, how do we know what's safe? How do we know what's not safe? And one of the best resources is something called the United States Medical Eligibility Criteria. And there's also the World Health Organization has a version, and there's also a third version for people who are in the United Kingdom. In addition, there's something called the Special Practice Recommendations. So the U.S. MEC, what that does, or the MEC, because as I said, it's for multiple countries, what that does is it shows each method of contraception, and it shows, is it safe in this user population? And it gives a rating, which I'll show you in a second. This SPR actually tells you, in all these different situations, how should we best use contraception? And so what the MEC does is it gives, for each of these conditions, it rates it a 1. There's no restriction for the use of the contraceptive method. 2 shows whether, yes, maybe there's sometimes where it's not the best thing for this individual, but usually the advantages outweigh the disadvantages. 3 is some of the disadvantages might be stronger, so you need to use clinical judgment in thinking about whether to prescribe that method. And 4 says it is an unacceptable risk to use that method. And then what they do, this is a very confusing table, but it shows you all the different conditions, and then for each method, it shows you whether it's safe or not. And the positive thing is that for most young people, young people tend to be healthy. And so what the MEC shows you is that for just based on age alone, there's no method that is contraindicated that gets either a 3 or 4 based on age. There are some things to consider, like the size of the uterus and other factors like that, but age alone is not a contraindication. So that's kind of a quick overview of different methods of contraception and how we think about the safety and the fact that we include young people in phase 3 trials, but also in phase 4 trials. I'm happy as we talk about questions to tell you about some of the studies that I've done with adolescents, which is the main population that I work with. But it's important for us to have the final take-home message, which is adolescents are very much included in clinical trials while they're under study, before they come to market, and also after they come to market. Thank you.
Thank you very much. Then we'll go to our next speaker. John, the floor is yours.
Looks like John's muted.
John, can you unmute yourself because I cannot do it. I think
Got it.
you've muted.
Okay. Thank you. Again, thank you, Emily, and I wanted to thank Clarissa and Melissa for the great overview on the needs of adolescents for contraceptive protection and information on the options and the safety of each. We wanted to add ethics to this discussion, in part because ethics is really about thinking about not only safety, but the interests and the participation, the voice of young people. And it's usually about a balance, looking at the risks and benefits. And in thinking about clinical trial service delivery, we understand that young people's freedom to explore developing sexuality and their independence has to be set against the need to protect them from abuse and exploitation, and the associated risks of pregnancy and sexually transmitted diseases. So this is a balance that individuals have to take into account, that for particularly young adolescents from 10 to 14, pregnancy is often the result of rape or incest. And in thinking about how we engage people in both trials and services, balancing their right to access as well as kind of what protections might be there. So what I want to do is talk about a few of the issues that we might look at in research and in services. We'd like to, I think, look at a balance between generating new knowledge and protection of those that participate. Melissa mentioned that most of the young people in are 16 and above, and that's the age where, at least in the United States, consent for health care is given. In earlier ages, depending on the context, the living situation of the younger adolescent, both male and female, there may be opportunities for them to participate in research in the same way, but understanding the conditions on which their safety would be protected. In these trials, the question for research is how do we ensure the process of informed consent? There's generally consensus that a 16-year-old can give consent. A 10 to 12-year-old may not. How do you address interests, conflicts of interest, and the public's right to information about safety and what's available? In terms of services, I think Melissa had a great table about the range of services that are needed in sexual reproductive health. How do we ensure these services are voluntary? In some countries where there are targets or incentives, people are pushed to use contraceptives. That's as true for young people as it is for older adults. How do we make sure that services are available and understood by those who are most vulnerable, from ethnic minorities, from those who don't speak the same language as the provider? How do we ensure that? And how do we maintain client privacy and confidentiality? There's a long history of ethics, and so we have a literature to go back on, from the Nuremberg Code in 1949 to the recent Council for International Organization on Medical Science, or guidelines for the international harmonization of standards. There's a long list of how to deal with these issues. In terms of policy frameworks, we have the UN Declaration of Human Rights in 1948, and then lots of treaties related to the Convention on the Rights of the Child, Convention on the discrimination against, elimination of discrimination against women, International Conference on Population Development, and each country has an office for the protection of human research. Countries and settings, we have institutional review boards that look at whose responsibility is to protect the rights of participants in research, to protect them from the risk of harm, to ensure that the benefits outweigh the risks, ensure that participation is voluntary, preserves the dignity of clients, and ensures their consent. In the service context, there isn't a board. It's essentially a provider and a client. So in some ways, these roles are mixed. Service people seeking services, young people, need to have a good idea what their interests are, as well as what their concerns about safety are, what their preferences, what their lifestyles are, what their lifestyle is. And the provider has to be sensitive and listen to those things, and provide both good medical advice, but also listen to the interests of the users. there's three key principles that are involved in looking at ethics, whether it's in a research or a service context. The first is respect for persons. The second is the balance between benefit and risk. It's called beneficence. And the third is justice or reproductive justice. Respect is essentially the autonomy of individuals to make decisions, their own decisions. So a provider shouldn't make a decision for someone else. They should be participating in it, but even for young adolescents, they should be the ones making the decision. It also involves protections for vulnerable groups, minors, pregnant women, fetuses, neonates, prisoners, in terms of research. And the way you do this is you set up a system for processing, know what they're getting into, and then oversight and redress in case of violations where people's rights are denied. In some ways, it's not only denial of rights by offering services that may be of poor quality or of inadequate information, but also denial of services to people who have a right to that care. Beneficence refers on trying to maximizing the benefit, physical, mental, and social well-being. That's where the notion of interests come in. So safety is critically important, but in dealing with adolescents, I think we have to understand what their situation is, what their partners are, how frequently they have sex, where they have it, what are the risks associated with their choices about this. The reference to doing no harm is essentially reducing risks to a minimum, the risks that would occur in daily life. And the mechanism for doing this is just doing a basic risk-benefit analysis. The notion of who takes the risks and who has the benefits from, and that may also be in terms of services. Who's taking the risk and who benefits from the particular product that is there. Benefits may include as the price of the product and who enjoys the benefit of that profit. It also means whose interest is being served by the use of the product. How do we protect more vulnerable groups? How do you make sure that all young people have access to participation in research, and when services are available, they benefit from the results of that research. What's the failure to act ethically for loss of funding for both research and service? Really, the loss of funding if there is documented unethical practice. Investigators and providers often lose the ability to practice. Certainly for researchers who need to publish, increasingly journals are requiring, peer-reviewed journals are requiring approval by an ethical review board or by a facility or ministry oversight of care. Civil suits are often placed against professionals who breach the standard of professional practice. Standards of care are very important. That's why I think Melinda did a good job in talking about what is the medical eligibility criteria and what are the standards. There are persistent issues in this area. The evolving context from research and services as well as the regulatory environment are changing. We have FP 2020 that is trying to respond to the needs of young people at scale. We have local governments that are making commitments for coverage. We have not all methods are available in every site, so choice and regulatory environments may be more conservative than those that are reflected in the guidelines in the US MEC and WHO. There's certainly a more diverse range of stakeholders, community, gatekeepers, and young people themselves. It's important, I think, that we continue to look at both civil society engagement in the delivery of services, as well as the voice of adolescents themselves. They have to have to include their concerns and interests, and I think this webinar is part of that process. In terms of informed consent, we have to have a balance between adherence to the principles of beneficence and justice with bureaucratic protections. Melissa can tell us how many pages are in a typical informed consent form in Chicago, but in many places we have to have a balance between how much information and who does this process really protect. There are conflicts between conscience and both on the part of the recipient of care, whether it's conscience, whether it's religious, or it's an ethical perspective, or belief about the hormones. We have to have kind of some balance to understand what are those concerns and share information where possible. And I think in each case we have to contribute to establishing of global standards. We also in individual settings, and we think that those settings are generalizable, but they may not be. But certainly the experience in practice, the research and service is important to continue to engage on issues of safety and rights. There are lots of resources for this. The U.S., the Office for Human Research Protections, NIH, WHO, all have excellent websites getting more information on this. There's a couple in Canada, Becca Cook and Bernard Dickens, who wrote a book on reproductive health and human rights, ethics and law in a very creative way, and they do it in terms of case studies. So that's also good for people who are teaching and try to understand how does this work in a larger context. So I think we have some time for discussion. Thank you again for your engagement in this important topic.
Thank you very much, John, and also Melissa and Clarissa. I think it was already very interesting, and I can imagine that there's quite some questions. So I would encourage everyone to still add your questions into the question box or raise your hand so that I can see that you'd like to ask a question. But we have a question here from Alexandra Wollum to Melissa, and Alexandra would like to know if she would like to hear more about how you have recruited the young people into the different clinical trials you've conducted, and whether you considered recruiting young people under the age of 16 as well into these trials, as they're also a potential user of the product.
So Alexander, that's a great question. So I want to first separate what I call the Phase 3 clinical trials and some of my own work, which I would, much of which are Phase 4, meaning these are products that are already in the market, and then my research is interested in understanding how young people use those methods. So for the Phase 3 trials, you can kind of imagine what might happen to a drug company or a pharmaceutical company that's trying to develop a new method. If you go very, very young, they get concerns about, could this be particularly risky? If something bad happened, that would not look good for my company. So there's really a tension between trying to learn about a method in a younger person at the time when it's coming to market, because you really want to you've put all of these years into the study. You want it to do well. And so that push to widen the age of who's included in a clinical trial, that's really come more from the government and from investigators wanting that information than necessarily for people wanting. So you always have to think about it as a little bit of a struggle. And that's why that age of encouraging 16, 17, 18 that's why that's sort of been the ages that people have focused on, because it seems like, 13, 14 are less commonly going to use birth control, and so that's kind of where that has come from. But that said, when you get to the phase 4 studies, those are very interesting populations to have this information, especially because for painful periods or for girls with disabilities or for other things where what we call menstrual hygiene, not having periods, is really important. We do need that information. So I have participated in studies and have developed studies so that we can understand some of the safety in younger girls, not as young as 14 and 15, but then also, but what I will say is that clinically we do use these methods, often because the advantages and the needs for the methods, for example, heavy periods where the young person has such bad anemia that they're unable to function or go to school, we absolutely use those methods. And so the last thing I will say is that even if you're not doing something in a formal study that you don't have lots and lots of data on from a research context, we also have a lot of knowledge from just clinical practice where we use these methods very, very regularly. And we have a sense that the basic biology of somebody who is 14 and 15 is not that drastically different than a person who is 16 and 17. So it is reasonable to assume that it is safe. And the reality is that we see very, very few, if any, complications, and they're not due to age.
Thank you, Melissa. That's very interesting. I think it also responded to a question that came up a lot already in our group, whether the fact that these young people who have a different hormonal level, whether it would have an impact on the contraindicators, but I think you just explained that we shouldn't worry too much about that. So thank you very much. I have another question from Genesis Luigi, who's asking what the role was of the parental consent in the trials where you involved young adolescents.
Oh, that's a really good question. So it really depends. So as John said, you have to go through a consent process, but it comes through having made an agreement with your institutional review board, your internal institutional research group. So in the United States, it's state by state, but in many states, young people have the right to get sexual and reproductive health care. In almost every state, you have the right to get confidential, without a parent's consent, access to sexually transmitted infection treatment. And in many states, not quite as many as sexually transmitted infection, but you are also able to get access to contraceptive care without the consent of a parent. Many institutions have said that is sufficient so that you don't have to get additional parental consent to participate in a clinical trial. But that's not universal. And so you would have to request a waiver of parental consent for participation. For the most part, we have been very successful in being able to waive parental consent for participation in contraceptive clinical trials, but it is not universal. And the last thing I will say is that because there are so many barriers, parental consent, all of these other questions, a lot of people just choose not to enroll adolescents. And so we at my institution, we've made a real point to go through all the hard work to do research with adolescents, but it is something that many people avoid.
Thank you. John, would you like to add something to that?
Yes, thank you. There's kind of two dimensions of it. Even when parents do give their consent, there's an obligation from an ethical point of view to ask the minor for their assent or agreement. So yes, all ethical review boards, when they require parental consent, say, well, the fact that parents consent to it doesn't mean that the young person is obliged to either participate in the trial or use a particular service. There are a range of values and belief systems about the role of parents in making sure that young people have health care. And what I think the ethical perspective and the way that Melissa's been talking about, it's kind of balancing about, well, how do we ensure protections for the young people and at the same time comply with legal and different types of conflicts. You know, if drug companies want to market something because they think that there'll be lawsuits, somehow we have to figure out how to deal with that and respond to the needs that we see in a clinical.
Thanks, John. And then we have another question from Lisa Mwaikambo, and she asked whether the concerns of young people regarding contraceptive safety are very different from postpartum women who are interested in spacing or not having any more children, because we of course know that their needs are different, but are their concerns also different? And are there maybe more myths among young people, or is there a lower level of knowledge? Just to know whether the messages around this counseling should be very different, or is it very unique, or can we just generalize it for those two groups?
I can jump in. I think that's an excellent question, and we talked a little bit about sort of the biologic differences between young people and older people, and I in some ways am pushing back to say there are limited biologic differences, and as you know, there are pregnancies in 14 and 15-year-olds. The main thing is that in the very early adolescence, the uterus is smaller, but the physiology and those things are established quite early on. But you raise a very important point, which is that the neurologic and the brain development and the cognitive development is different for younger people. So this idea of thinking about the way the body develops and the way that the mind develops, that's a really important thing to think about them differently. So yes, I think different counseling styles are needed for early adolescence, which we typically say is sort of 10 to 14 versus middle adolescence, and for later adolescence. In earlier adolescence, it's much more difficult to understand abstract concepts. It's much easier to understand very specific examples. In middle adolescence, specific examples are also needed, but in older adolescents, speaking in generalities is often just fine. So there have been some efforts to really try to think about how to counsel adolescents differently than adults. But I will also, and I can tell you some of those references. Those are that's work that's been done by the Centers for Disease Control. But I will also tell you that we don't have that much research on the best way to counsel. So as much as we counsel and study counseling, there's also limited research.
And if I could just jump in as well, Emilie, this is Clarissa. I think one of the areas that we're really interested in right now is conducting deeper kind of acceptability and desirability research, calling ideation research with young people, and trying to really include those who are under the age of 18. And again, this is always subject to ethical review, and those reviews vary depending on the country we're working in. But really trying to better understand what is the side effect profile that these younger adolescents who are nulliparous, so they haven't started childbearing yet, what are they really interested in? And I think we know that return to fertility is really important in certain geographies for certain segments of women. And so being able to design methods that do address that particular need, I think, is really important, and something that the foundation is just now starting to invest in, with that specific focus on 15 to 19-year-olds who are sexually active but who haven't started childbearing.
Thank you. And then we have a question from Elizabeth Westley, who's asking whether also within the US they're using a system which is called Gillick competency, and it's used in the UK to determine if a minor can make their own decisions. And she was wondering whether it's also used in the US already, or whether it's something that's only been used in the UK at this point.
I was going to let John answer that.
There we go. It's Gillick's mentioned in the literature. I don't work in the United States, so I don't really know if it's used in the United States. It does provide an alternative to just personal opinion about someone is competent to make those or prepared to make those choices. As Melissa said, there's a brain development and judgment. It continues through the early 20s, and so this is a fluid context. I do think some of the questions that are in the Gillick chart would be helpful as part of the counseling process. Whether it's applied systematically, I don't really know. We could certainly share it with people on the webinar if they're interested.
Yeah, I would love to see it. I just happened to have participated recently in a grand rounds on clinical competency, and there is not no one mentioned a formal tool or process that is used. It's still clinical judgment. So I'd love to see it.
Okay, we can definitely share it with the recording and the presentation. Another question is from Abdul Wadud, who wanted to know whether how we can increase the availability of youth center reproductive health supplies, and that's also a question that comes up a lot in our group. Shouldn't we be looking more towards the needs of young people and developing products from what we hear there, rather than just looking if products that are available are also safe for young people?
Yeah, that's a great comment, and it's as I gave my presentation, I realized I finished by sort of saying these are the methods and these are why they're safe. But I think the other thing that comes out in your question is to put my comments and John's comments together, which is to say, it's great that there are all these methods, but what do young people actually want, and what are they willing to use? And so this idea of designing things with people kind of at the center and the needs of young people at the center, I think that that's really the pathway forward, whether it's how we counsel people or how we design a method. There's a little bit of that starting. There's just the National Institutes of Health in their contraceptive development new research request for new research sites. They asked for people to, as they developed the drug, to also have someone who's thinking about behavior, having them work at the same time. That is a huge, huge step forward to even begin to start thinking about the role of behavior and what human beings want at the same time that you're developing a new method. And I use that example so that you can kind of understand that it is, it's a very different way of thinking, and part of that idea of trying to really focus on safety has been such an important part, and focusing on effectiveness, but now focusing on the user is definitely a different way of thinking about it. And I want to point out that it's going to be really hard because if you're starting from scratch, these methods take decades to develop. But if you're starting from something that's already far along, I do think that that's a very strong possibility to sort of think about what the user wants at the same time. So I think it's a great insight. Note that it's very, very challenging, but I think it is an important way to move forward.
And if I could just add, Melissa, I completely agree, and this is something that the foundation is currently working on and thinking both about what are the modifications that would need to be made to existing methods, and what is the kind of longer term strategy, what are the new methods that would need to be designed to meet young people's needs. And that really is thinking about, you know, a post-2020 world, you know, where we still will have large groups of people, including young people, who have unmet need for family planning, and how are we designing methods for them based on what they're saying they want to meet their needs. And this is really where we are doing that user-centered research in 2 countries, starting in Kenya and in Vietnam, looking more kind of broadly at what are the characteristics of methods that young people want. So even before kind of phase 1, but more along the kind of acceptability, desirability, and then moving into actual products from there. So completely appreciate the question and say this is something that the foundation is currently working on.
Thank you very much. Fortunately, we're coming till the end of our hour. I just wanted to ask one more last question to all of the panelists. With the youth group, we're at this point developing a key messages document that we'd like to use as our main asks for policymakers. And it contains lots of different points already regarding access to reproductive health supplies for young people. But I was wondering if you be able to give one message or one ask to a policymaker related to the discussion that we had today. What would it be? So maybe we can use it in our document.
I would say that the message should be around the last point. So while there are many contraceptive methods available, we need to understand what young people want and make sure that methods are available that young people want.
Maybe I could jump in. I think, you know, in the GFF and many strategies, young people are highlighted, but the level of investment in actually getting service to them and maintaining pipelines to perhaps not the usual places where people go for care, whether those are youth centers, other networks, drug outlets, that youth might use because of either preferential cost or because they provide confidentiality. I think we need to invest more, or that national governments invest more in actually getting services to young people. We know that condom use among young people, particularly in sub-Saharan Africa, have increased dramatically, but still not at a level that would provide the protection they might need against unwanted pregnancy and unwanted infection.
Completely agree with both of those points. I would just add services, information, and products need to be designed and implemented that meet young people's needs and that are developed in collaboration with young people.
Thank you very much. think it was a very, very interesting webinar. I'd like to thank all of our speakers, and also like to mention that this is not the end. We're really trying to set up webinars that are looking forward to all of the issues that we're within our group are thinking about or have questions around. And one of the next parts webinars that we want to do is to really look at those needs of young people and find different researches that already have been done or consultations that have been done and try to bring them together and explain a bit more about the needs. So this was definitely a first step in a series of webinars. I think it was very interesting, and also looking at all the questions that are still on my list. I think it was also interesting for the participants. So thank you very much, and we'll hope to have you all on our next webinar.
Great. Thank you so much.
Thank you. Terrific. Bye-bye.
Bye-bye.
Bye.